Very excited today. Very excited to have with us Dr. Daniel Restrepo, who's usually you will see him on Monday subspecialty VMRs doing clinical reasoning, but today he's coming in taking a role of a presenter of POCUS VMR today. So he'll bring a case to us, which we're very excited about. And I also want to introduce Dr. Anne-Marie Kumpfer, who is with us today and will be co-discussing. Anne-Marie, do you want to unmute your mic and just say hello to everyone?
Hey everyone, I am so happy to be here. I've had a busy stretch, so haven't been able to make VMR as much, but so happy to be here today to get to learn and discuss.
Oh, great to have you today. It's sort of like old times. Yeah, initially started co-discussing with Anne-Marie back in the day. Oh, and I also forgot that Dr. Daniel Restrepo, could you unmute your mic and also introduce yourself?
Hello, everyone. My name is Dan Restrepo. I am an internal medicine doc at Massachusetts General Hospital in Boston and one of the associate program directors. And I'm also in charge of resident education and point of care ultrasound. And so I'm really happy to talk about two of my favorite things with all of you by way of a case, clinical reasoning and point of care ultrasound.
Awesome. Thanks for making time and coming on today. And we have scribing and teaching points. I think Sammy and Shema, would you like to just say hello to everyone?
Hi, everyone. I'm so glad to be back on VMR. I spent some time off, was in the US and did some rotations, and now I'm back. And I couldn't have a better start with Dr. Restrepo. He's a legend in my eyes, and I'm striving to be one day like him. So yeah, I can't wait for the discussion.
Too kind.
Hi, I'm Shema, and I will be doing the scribing today, and I can only echo what Sammy said. I can just recommend watching the last VMR with Dr. Restrepo and the great mnemonic. Yeah.
Awesome. Okay, we'll get started with the first aliquot, and please deploy the whiteboard.
All right. So today we're going to be discussing the case of a man that I took care of on the wards, and the chief concern is dizziness and malaise. So dizziness upon standing and just globally feeling unwell.
What do you think,
so
Anne-Marie?
This is a 50.
Okay, sorry.
Oh, go for it.
Yeah, I was going to ask Anne-Marie, any ideas before we get going with the HPI?
Yeah, I think this is a really common complaint and can have just a whole host of from benign causes to very serious etiologies. So whenever someone says dizziness, I try to clarify what they mean by that. Is it more vertigo? Is the room spinning? Or is it more a feeling of lightheadedness? The fact that we were told that it occurred when standing definitely makes me question more kind of orthostatic etiologies or something related to autonomic insufficiency. So a lot of times kind of the low-hanging fruit that I like to do myself is seeing what's the blood pressure and then getting orthostatics myself, because it also gives me a lot of information about how they stand, are they steady on their feet, and kind of other etiologies. So I think that's one of my first branch points thinking about this is kind of thinking about what's the etiology, and then the malaise could be a whole host of other etiologies. So definitely here it's a broad differential. I'm going to want to know about their past medical history, because this could be a whole host of cardiac, pulmonary kind of etiologies and everything here. I'd want to know about their medications, any recent falls or trauma. So it's a really wide differential. And it's definitely, I'm going to want more information going forward. Ravi, what would you be thinking?
Oh, I absolutely love that first branch point. I am all on board with that. If you have orthostasis, it's a simple fix. You give some fluids and actually watch for an improvement in the drop in the blood pressures. But I think Dan is bringing us a case that won't be just simple orthostasis, and something that will be narrowed down with the use of POCUS. So all the different systems is quite early on with this complaints. I think malaise may be a traveler with dizziness. And what I usually worry about with dizziness is there's many causes, non-specific. There could be vertigo. With vertigo, I worry about peripheral, central. Central, you want to highlight if there's possibly a posterior circulation stroke. So things like that, worry about something maybe intracranial, then all the other extracranial features come around, like cardiac and so on. So we'll see what else he has in store for us with the HPI. Daniel, back to you.
Okay, so he's just been feeling kind of out of it for the last 1 to 2 weeks or so. He specifically has not had nausea, he's not had vomiting, he's not had diarrhea, he's not had cough or fever or rigors, he's not had any belly pain, but can't really pinpoint what's been happening very clearly. His medical history was notable for hypertension and an alcohol use disorder, which was reportedly in recovery. So he voiced sobriety, and his medications included valsartan, and that was it. And he had no known allergies. If we want a little social history, he works in construction. He does not smoke. He does not have recreational drug use. He lives with his wife, who is concerned that he has relapsed. Should we pause there?
Yeah, we can take a pause there. Is that relapse with alcohol use?
Alcohol, yeah.
So that I'll take a stab at this, Emery. Then you back me up with while I discuss. See what you think. But I'm going to highlight the alcohol use. Of course, hypertension, being on valsartan, if for some reason his blood pressure drops, and a lot of times patients continue taking their medications, they could possibly exacerbate that blood pressure. So his blood pressure could be really down in the dumps. But with alcohol use disorder, what could possibly lend to this? Alcohol can target many different systems, namely if we were talking about the vascular system and volume. So a lot of times alcohol use disorder can manifest with volume depletion. It can act like a diuretic. It can also have toxic effects on the heart. So cardiomyopathy, as Anne-Marie had mentioned, cardiac effects could result in syncope. How about nutritional disorders? So thiamine deficiency and anemia. So this past weekend, we had a great student VMR where a patient had anemia, and most noticeably with the alcohol use disorder, you could have a macrocytic anemia, and that can definitely result in volume depletion and orthostasis. So a few things there. I think autonomic dysfunction, as Anne-Marie had mentioned, could also be exacerbated by alcohol use, and also chronic cognitive changes and effects. So central issues could definitely happen with alcohol use. You can end up having atrophy. If for any reason, as is brain shrinkage, a patient falls, they can very easily have intracranial hemorrhage. But I don't see anything in the HPI that shows us that patient had possibly fallen or had any intracranial trauma. But those are a few things I'm thinking about. I definitely think the patient may be taking valsartan, and that the blood pressure may be very, very low because of that. But that's just one of the thoughts I had. Emery, what do you think?
Yeah, I love those thoughts. I think that this sometimes what makes these cases difficult is usually when I'm going in to see a patient, I already have initial vital signs. Oftentimes I have some labs too. So here, I think the vital signs are really going to help us, but then I'd also want some vital signs under stress conditions, as I talked about, seeing what they are at rest. But if they, just because they're normal at rest does not mean they'll be normal under physiologic stress, such as standing, such as walking, and things like that. So I definitely want to see kind of initial vital signs, and then especially if those were normal, but also see like what changes there with walking. What does the oxygen saturation do? What does the blood pressure do? What does the heart rate do? Because I feel like that's probably going to give us a lot of information here as to what's going on. I always like to know baseline functional status, because that also gives me a really good idea. It sounds like this person is a construction worker, so probably has really good baseline functional status. So the fact that they're coming in today, it probably represents the fact that their body is probably under pretty significant physiologic stress. And so that's something I definitely want to like take seriously and evaluate. So I definitely think that the vital signs and then perhaps the labs will give us information. I completely agree with you, kind of the concerns of the alterations in physiology that alcohol can have, like from thiamine and everything like that. But I definitely wouldn't want to be so focused on that I missed other etiologies too. This is a middle-aged male. He could be at risk for developing like other cardiac etiologies, like ACS, like some sort of conduction abnormality. So I really think that to move forward, the kind of further labs and exam are going to be really helpful. Any further thoughts, Robbie?
Yeah, actually, just from you going through the motions of the cardiac and so on, one particular arrhythmia comes to mind, atrial fibrillation. So there is this entity known as holiday heart. But atrial fibrillation can occur as you have structural changes to the heart. Another thought is, I love that discussion that you had about moving the patient, seeing the patient in motion to see if there's any sort of cerebellar effects. You can get cerebellar degeneration with alcohol use. Disequilibrium is a component of dizziness, just as presyncope, vertigo, and non-specific dizziness. So just a few thoughts there, but you're right, it's still early on. And I think having some data in hand will help us narrow down and weed out some of these, this large list of thoughts that we have. Back to you, Daniel.
Okay, so his vitals on presentation to the emergency department were notable for a blood pressure of 90 systolic over 70 diastolic with a heart rate of 110. His temperature, his respiratory rate, and his oxygen saturation were all normal. The blood pressure upon standing was 60 over palp. He was dizzy, and his heart rate augmented to 130 in that case. On physical examination, jugular venous distension was not noted. However, he had a large caliber neck, thus hampering a very clear assessment of it. His extremities were clammy and a bit sweaty, and he had no abdominal tenderness. I can give you guys a list of interventions which happened at that point in time. He received approximately 3 liters of fluid in the emergency department, and his blood pressure only rose slightly, so not very much at all.
On exam, were there any, I know this is kind of an initial exam, but were there any like murmurs, muffled heart sounds, anything like that? Coolness of the extremities?
So just kind of cool, clammy extremities. No, he was he's a larger gentleman, so the heart sounds were sort of faint, but no overt murmur was heard or rub.
Okay. So I will start out. I am very concerned about this gentleman. He is manifesting signs of shock with a low blood pressure and then the cool extremities. It seems like his heart is trying to likely compensate for this shock with the tachycardia. And it does seem that he does show orthostasis as well, and that his systolic blood pressure decreases more than 20 on standing. So I'm very concerned about this gentleman. And now in my mind, I'm going to be going through my shock etiologies. So kind of one of the first things I think about with shock is kind of thinking about my big buckets. So is this volume related? So is this hypovolemic or hemorrhagic? So I'm going to be kind of like asking and thinking about sites where blood can be lost, looking for pale conjunctiva. You can look at the hands, if you see paleness, oftentimes that portends a hemoglobin less than 5. The fact that he didn't respond to fluid, and a pretty significant, it sounds like 3 liters, which you would expect response, makes me think hypovolemia is less likely. And then I'm going to be thinking about my cardiac etiologies of shock. So the JVD can be very helpful in assessing cardiogenic, but sometimes it can be difficult to assess, which is where our POCUS exam can be helpful. Thinking about looking to see, is the heart beating correctly, trying to visualize the IVC as well. The IVC is can be used to kind of help assess pressures on the right side of the heart, although you have to be careful if you don't know if there's pulmonary hypertension or tricuspid regurg. And then besides cardiac, I'm going to be thinking about mechanical. So could there be some sort of cardiac tamponade, something like that going on, which is why I was asking about the muffled heart sounds, which is also why, looking at the JVD is very important. And then thinking about PE as well, which we could also assess on POCUS, looking for signs of right heart strains. We could look at a D sign, a McConnell sign, although the D sign just points to elevated right-sided pressures. It does not point to an exact etiology. You could also do a quick exam looking for signs of DVT as well with it. And then also thinking about distributed shock. It sounds like he's a little bit cool, but it sounds like he's a little bit sweaty and diaphoretic, but like his extremities are more cool rather than hot. And with a narrow pulse pressure, that's leading me a little bit more away from distributive etiologies, but I definitely still want to be thinking about that. Sepsis, it doesn't sound like there's signs of anaphylaxis, doesn't sound like there's trauma that would make me think neurogenic. So those are kind of how I'm approaching shock. Ravi, what are some of the next steps you'd want to take and some of the evaluations you would want to do when we're thinking about this gentleman?
Anne-Marie, that was such a good walkthrough of shock and something that everybody here should really know. So that was, I really applaud you there for a wonderful journey through the landscape of shock. And it's one of my favorite simulations to run with students. And although not as severe as this, something rudimentary, but with residents, something that they have to know. So as Anne-Marie had mentioned, we're in the domain of refractory shock, and I really like you picking up on the pulse pressure. Now, we do elaborate on wide pulse pressures here quite a bit, but a narrow pulse pressure does go with hypovolemia. So, but what's puzzling here is we've given a few liters of fluid, and it's still refractory. So, treatment refractory shock, what could that be? If you're losing more volume than what you're putting in, so massive hemorrhagic internal bleeding, somewhere where you're not able to keep up with losses, could there be another process? So severe septic shock, but again, this doesn't, like you had mentioned, the cool extremities. So what happens? Why are the patient having cool extremities? Possibly due to clamp down and shunting away from areas to maintain perfusion to vital organs, namely the internal organs, the heart, the brain, and so on. So peripherally, you will be shutting down. Could there be going into that domain of obstructive shock? So several things come to mind. I mean, I've seen a number of pulmonary embolisms, and a lot of learners here may say, like, wait, there's no dyspnea, there's no hypoxemia, there's no chest pain. That's what we usually or classically taught about pulmonary embolism. But I've seen a great number of pulmonary embolisms that are very atypical. So you start by learning the basics, which is a patient with a prothrombotic disorder, a patient with chest pain, dyspnea, hypoxemia, and hypotension, tachycardia. But you don't necessarily have all of those present at the same time. Maybe as a patient progresses through the shock part, they may start to have chest pain and so on. So cardiac tamponade was a great thought as well. I thought about constrictive pericarditis. There's a large neck. We don't always see a JVP, so that doesn't discount this cause. Atrial myxomas, abdominal compartment syndrome, I think I mentioned that, and tension pneumothorax, but that would be, I would like to see some respiratory component to that as well. So I agree. I'm sort of hanging on to the coattails what Anne-Marie had mentioned, and we'll probably need POCUS to narrow down narrow down some of these differentials to get to the right diagnosis. Back to you, Dan. Oh,
It's very convenient that this is a POCUS VMR.
Why do you think I hang out on POCUS VMR? Back
All
to
right.
you, Dan.
So maybe we'll give you a lot of the case here is also in the lab. So, but I'll start by telling you that his electrocardiogram had normal voltages and just showed sinus tachycardia without concerning ST or T wave segment changes, normal R wave progression. All in all, a pretty normal electrocardiogram. And he did have a CT of his abdomen and pelvis that showed no intra-abdominal pathology, as well as a chest radiograph that was completely normal. And the labs. Okay, so his basic metabolic panel was notable for a creatinine of 2.5 from a base of about 1, a BUN of 50. He had a normal sugar, a normal sodium, and normal potassium. And his bicarbonate was 16. His magnesium was low at 1.6. His aminotransferases were notable for an AST of 230, an ALT of 100. Alkaline phosphatase and bilirubin were normal. His hemogram showed a white blood cell count of 2.5, a hemoglobin of 9, platelets of 80. And then his lactic acid on presentation was 3.5, then rose to 4, and then rose to 4.8 throughout the course of those fluids.
So Robbie, do you want me to, I can discuss the BMP, and then if you want to discuss the CBC?
Sure, go ahead.
So I think just looking at the BMP, as was mentioned in the chat, always something you want to think about with shock without a clear etiology is adrenal insufficiency. But in about 80% of cases of adrenal insufficiency, you should see hyponatremia. Hyperkalemia is less common, and that will be with primary because you get the aldosterone deficient state, but that's not present either. And the normal glucose is kind of moving me away from that. I am unsurprised by the elevated creatinine because this patient is showing signs of decreased tissue perfusion. And in shock, you often get end organ damage. And so I do want to kind of know what's the center of gravity, but the elevated creatinine and the elevated liver enzymes are not necessarily surprising to me. I'm worried that these are a manifestation of the decreased tissue perfusion. As far as the bicarbonate, I also worry that this is acidosis related to the shock state, especially with the rising lactic acidosis. I don't think I have the labs to calculate an anion gap, but that would kind of all go along with this, although, you know, tissue perfusion and everything, or the elevated creatinine could be contributing too, but I tend to think that this is probably related to tissue perfusion. Definitely kind of like thinking about distributive shock. I would want to be thinking about, could there be any biliary pathology or anything like that? But I think right now my highest concern would be more related to tissue perfusion. So kind of, and then I guess on the lactic acidosis, it is concerning that it's continuing to rise despite fluids. Whenever I think of refractory lactic acidosis, I want to be looking at, you know, the blood pressure to say, like, have we fix the perfusion problem. And then I always think about kind of with this, if there's another clear etiology, that occasionally you can see this with thiamine deficiency as well, especially kind of pretty elevated causes. I don't see kind of any other exposures that would make me think of like electron transport chain problems or things like that. Robbie, what are your thoughts on the CBC and kind of any other thoughts on the BMP?
Sure. I just want to start with the BMP. I really like that you picked up on. I'm not worried about the renal failure. What happens sometimes, we usually look at the numbers and we get very excited, like, okay, we got to fix the cranium, we got to take care. There's some problem in the liver, but you got to look at it as a whole. So, like you mentioned, what is the center of gravity here? What is the problem that we're facing with, which is refractory shock? And this is all secondary to that. So it's all noise. And where is the signal? The signal we're still trying to tune into. Yeah, the AST-LT is interesting. The AST is greater than the ALT. They're both elevated, but again, this is not shock liver. AST could be, if you look at the CBC, there's anemia as well. You can't help think of hemolysis. Could they also be tissue necrosis somewhere, rhabdomyolysis? And that could also manifest with AST elevation as well. AST could also manifest from liver and also from creatinine. The lactic acid, again, I'm not even sure if there's liver involvement, if there's primary hepatocellular damage here, but lactic acid can rise in the face of decreased liver breakdown. But I think you're right that the lactic acid likely is responsible for the acidosis here. I don't know what the anion gap is, but I anticipate it being HAGMA. But just tackling the CBC, you have pancytopenia here, which is unusual. Why would this patient, 55 years of age, having refractory shock, have pancytopenia? You definitely need a baseline if there was a baseline available. How long ago did this start?
About a month ago, it was normal.
Okay, so over a period of a month, this patient's CBC has all cell lines have steadily started to decline. So how would you approach that, or how would you approach a framework? So, could this be something outside the bone marrow? Could there be sequestration, destruction? We kind of talked about hemolysis. Could this be bone marrow failure, or could there be something infiltrating into the bone marrow? Or could this be something in the background, and on top of this, patient is manifested with shock? So a shock state in the presence of pancytopenia, taking the white cell count, could this be like a neutropenic issue where you're immunocompromised and you can have devastating infections with fungal infections or other multi-drug resistant organisms like Pseudomonas? There's no fever there, however, so I doubt we're in the domain of neutropenic fever. But I'm not quite sure how this plays into that. But I guess when we went back to the blood pressure and the narrow pulse pressure, somebody mentioned in the chat, narrow pulse pressure could be hypovolemia, could be a cardiac issue. I'm still kind of wondering. And then again, 1 liter of fluid and the blood pressure rose only slightly. The only recent case that came to mind where a patient walked, talked, looked like septic shock and had blood pressures that were refractory to several liters was actually a case of pulmonary embolism that we were able to determine using POCUS and the D sign on the biventricular view, so the parasternal short axis view. So that comes to mind, but at this point, I am not sure why this patient has pancytopenia. But again, starting with a framework of either bone marrow failure, and it could be immune mediated, it could be nutritional deficiencies, bone marrow infiltration. I don't get a sense of something that's nefarious and lurking in the background and infiltrating the bone marrow. We're not seeing any signal of like weight loss or other key physical examination findings. And could there be sequestration, no splenomegaly or so on? So I'm sort of stuck at this moment. So any ideas, Anne-Marie, on the CBC?
I guess it's a CBC that I'd want to pause and say, I want to look at a smear, because as you mentioned, with the AST being higher than the ALT, I think there's a lot of etiologies, but the smear, if there were schistocytes, we could have DIC, so getting coags, I think would be really helpful here. And then we could also see, do we see any like abnormal tick-borne inclusions or anything like that, although those are present in the minority of cases. And then I'd want to see a retic count, hemolysis labs too, to just try to get a better idea of what is causing this, because it certainly could be like a massive sepsis. Sometimes you can see pancytopenia. It could be liver disease. We could look for splenomegaly, although it seems relatively acute. And then, yeah, I just want to kind of see a smear and everything to get kind of a better idea of what's causing the pancytopenia.
Awesome. Yeah, I love that. Narrowing down on the first test or intervention should be a peripheral smear. So great. Back to you, Daniel.
So I'll give you just his differential was relatively normal. His smear was fine. There was no schistocytosis. His coags were DINR was 1.2 or 3. It wasn't anything crazy high, and I don't think markers of hemolysis were sent. But this is a fantastic discussion thus far, and you guys have brought up so many salient points and a lot of things that we, the clinical team, were feeling in the moment. Namely, is this incipient cardiogenic shock? And so, and for the learners on the call, if you remember nothing from this, is that blood pressure does not equal perfusion, and that you can see some horrible things with a normal blood pressure, and that person very well can have shock even if their blood pressure was normal. So we grabbed the probe, and our clinical question was, are there sonographic signs of either cardiogenic shock or obstructive shock? And that's what we're going to take a look at. So what organ would you guys want to first look at?
What do you think, Anne-Marie?
Let's go with the heart.
Let's go with the heart. That sounds good. Can I take over the screen sharing? All right, and then so this is going to be it, and we are going to take a look at the heart. Can everybody see these clips?
Yes.
All right, so there are two cardiac windows on this screen. Anybody want to take a stab at this one? The first one on the left, the medical right.
I'm kind of happy you have two views, because Dr. Gigi Liu, Dr. Ria Dansa, they always mention Sandhya Patel and Dr. Galen. One view is no view. So we have two views. So we have appropriate views here.
So first we're looking, so this is the parasternal long, and then this is the parasternal short. So I do not pretend to be a POCUS expert, so if someone wants to jump in, but some of the things that I look at the parasternal long, here we can see at the top, you can see the right ventricular outflow tract. At the bottom, you can see the left ventricle, and then here you can see the mitral valve. When I look at it, I'm looking at kind of the wall squeeze, and then you can also, if you don't have known mitral valve pathology, see, does the mitral valve look like it's coming up and slapping the septum? Usually it should come within like 1 centimeter of the septum. It looks like we might be, I forget what the rhythm was. I think it's a little bit of a short clip. I can't tell for an atrial fibrillation here. It looks a little bit abnormal. So I'm having a little bit of trouble interpreting it, but I definitely don't see great mitral valve motility, and it definitely looks like it's not coming within 1 centimeter. Then we can look at kind of the walls squeezing together. And Ravi, do you want to, and then the other thing I look for is, do I see kind of signs of fluid around the heart? The subxiphoid is the best view to look at it, and you can definitely sometimes see a pericardial fat pad behind the right side that kind of should have a little bit of sparkliness rather than like the pure fluid look. But Ravi, do you want to kind of, what are your thoughts and looking at this, and maybe Dr. Restrepo can help us out.
Oh, Anne-Marie, that was a great walkthrough. I really liked your description there. That was very like expert with, especially with the mitral valve. So brilliant read. And I completely agree there. Yeah, what we learned from Dr. Gigi Liu, we're learning a lot during these POCUS VMR. So this rule of threes, and Dr. Sanjay Patel did elaborate on that last week as well on his VMR. So looking at the right ventricular outflow tract, and then looking at the aorta and looking at the left atrium, they're pretty much approximate. So I don't see a massively dilated right ventricular outflow tract. I don't see aortic stenosis or any hyperechoic findings on the aortic valve. And so looking at the pericardium, you don't see, like you said, no anechoic signal there to suggest pericardial effusion. But looking, somebody had noted in the chat that the walls may be a little thicker. I can't really comment on that. Maybe the bottom wall, maybe of the left ventricle, a little thick there. But yeah, what sticks out is there was noted tachycardia, but this looks maybe a little on the slower side to me, unless the image is being played at a slow speed. But yeah, the squeeze is not terribly is not terribly normal, and the anterior mitral valve is not excursing and hitting the septum there as we usually see. So that would be a sign of good LV function. So I think, yeah, there is some LV dysfunction, and looking at the parasternal short axis on the right there, the squeeze is not complete. Again, the right ventricle isn't massively dilated. It looks like it's sitting on top of the left ventricle, not compromising the left ventricle, and also the septal wall is not flattened. Anything there, Daniel, you want to
yeah, so this is a great, there's a lot of information here. You guys have already touched on a lot of it. So I will say that the clips from the actual patient were not working for some reason. So these are representative images, which is maybe what explains the difference in the heart rate. I will start out by, again, you guys have all correctly interpreted, identified all of the correct anatomic structures here. As far as to the LV function goes, the beauty of POCUS is that you know your patient, and oftentimes beyond that, I'm asking myself, you know, as I'm going to see this person, is this an LV function that would be commensurate with a lactate of 5 and visceral congestion and acute kidney injury and things like that? And in my mind, I would say that this heart looked pretty okay to me as I was going to see them. So if you take your finger and you sort of put it where the cursor is, are those walls coming in? And you're not catching that long of a clip here, but they are kind of thickening there at a decent amount. And then is this anterior mitral leaflet swinging open and diastole? And you kind of have to look at 1,000 of these, but it's moving rather quickly. And I think it's probably from the clip, but I would venture a guess that that's a pretty decent mitral valve excursion there. It's just probably in one of the beats, it didn't move as far as it is. The other thing is, are all of the walls kind of thickening on this side, on the parasternal short? And they are. They're all kind of coming in nicely. This is the papillary. These are the papillary muscles that are right here, and all these segments seem to be thickening in nicely towards the center. Like if I were to put my finger again in the center of that, is everything moving closely into the center of this left ventricle here? And what Dr. Singh had said, so this is the parasternal short axis of the heart. And I usually think of this as I call it the donut and the croissant view. The left ventricle should look like a donut. The right ventricle should look like a croissant, and they both do in this case. So the RV is not terribly blown. There's no D sign, which has been mentioned a couple of times, which should be a sign of RV pressure overload, where the septum of the left ventricle flattens, which we're not seeing here. So, you know, I can appreciate why a couple of these beats don't look like it's coming in entirely nicely, but as you're going to see this patient and you're grabbing the probe, is this a heart that looks sick enough to make somebody as sick as this guy is, or is it not? And that's kind of how I was phrasing it in my head as I went to see that. And we got a few more views here, which maybe will give us a little bit more clarity. And so just I can help us out here, but over on this side of the screen, we have a subxiphoid view, as Dr. Kemper said earlier. the best view to look for pericardial effusions. And so the suspicion was already low for it, meaning that there was probably not a big circumferential pericardial effusion that we saw in the first set of clips. However, this really kind of puts it to rest. So this big piece of meat that's in the near field, this is the liver. And then the pericardium is bright right here, so that if there were to be a large pericardial effusion, there'd be an anechoic rim around the heart that we're seeing. So this is your left ventricle, back here is your left atrium, your right atrium, and your right ventricle. And over here, sort of all the chambers seem to be squeezing nicely. Then moving over to this clip, which is the apical 4-chamber view, in which you have the left ventricle here, left atrium here, right atrium here, right ventricle here. This is a great view to actually assess for chamber equality, meaning is my right RV as big or bigger than my LV, which would be kind of a sign of RV strain or RV pressure overload. I'll call your eyes to this. This is the free wall of the right ventricle. And if you were to kind of take imaginary calipers and measuring it to the septum, it's not grossly larger than the left ventricle here. And again, there's no circumferential pericardial effusion. And in this view, you can maybe see that the mitral valve is kind of swinging open and closed nicely. And then it's a little undergained, meaning dark, but these walls also look to be apposing pretty nicely. Okay, and with that, I will stop sharing. So the clinical team was worried about this patient, as our discussants aptly have voiced the same concern. And as I was going to see this gentleman, I also framed him similarly as a 55-year-old man with hypertension on an ARB and an alcohol use disorder, which was reportedly in recovery, however, presenting with dizziness, narrow pulse pressure, and severe fluid refractory lactic acidosis. And going in my head, I was worried that this was this either kind of an occult alcoholic cardiomyopathy, or did this represent a type B lactic acidosis, perhaps in the setting of thiamine deficiency? And the power of POCUS in this case is that it made me feel a lot better that his heart really wasn't explaining all that other stuff that was going on with him. And so the next diagnostic test was actually a therapeutic test. Anyone want to take a mention before we reveal it?
So, I mean, I would definitely start him on the high dose IV thiamine in this case, just to kind of assess response, just for completeness sake, although I don't feel like all the clinical features fit. I'd probably check a TSH too, but I don't really see signs of that. So I think that high dose IV thiamine, and then I don't know kind of how his IVC and everything looked.
Oh, whoops, I forgot. That was the last screen. I apologize. I'm gonna take over this for a second. And it was
okay.
So here we have the liver, this anechoic sliver in the liver is the hepatic vein, which is, as you can see, draining into a horizontal inferior vena cava. I counsel people never to make their decision right here, because the diaphragm will exert an effect on the IVC and make it look compressible. So call your eyes a little bit further back, all right? And we want to see is, first off, is the IVC distended or not? And then distension is defined as greater than 2 centimeters, and then collapsed or thin would be on less than 1 centimeter. Here you can see that it's probably about 1 to 1.5 centimeters wide. And then when he breathes in, there is some inspiratory collapse. So again, if we were worried about obstructive physiology or cardiogenic physiology, we should expect to see more distended, a higher central venous pressure, which is what we're kind of trying to estimate using an IVC. So not crazy overloaded, not crazy, totally underloaded in terms of his filling pressures on the right.
Okay. Perfect. Well, I think that would definitely, and we could also look for signs of B-lines and everything, but it sounds like there's no oxygen requirement. I think that would make me feel more confident, knowing there's normal squeeze. You could assess fluid responsiveness with a straight leg raise, but it would make me feel more confident about trying additional fluids as we're trying like IV thiamine and other interventions. Ravi, what do you have to say?
Yeah, absolutely. So how did the patient do, Daniel, with the thiamine? Did that resolve the issue?
So, Dr. Cooper, you did exactly kind of what was our reasoning here, in that, in thinking that, you know, fluids are medicines and that we don't want to just give people them willy-nilly. This certainly appeared to be a sonographic picture that was fluid tolerant, as some people would phrase it, meaning that fluids may help me, but they're probably not going to hurt him. And so we started him on IV high dose thiamine, and his lactic acidosis melted away by the next day. His organ function parameters also got a lot better. So his end organ parameters, like his liver and his kidney, also got better. And this wasn't a perfect case. This was noisy, but this is clinical medicine, and this is, I think, what illustrates how POCUS was so powerful in this case, because everyone, at least on my team, and our expert discussants today, we're worried about his heart going into this. And I think the central question that we use ultrasound to answer is, does his heart look sick enough to explain all of this other stuff going on? So we diagnosed him with a relative thiamine deficiency causing a type B lactic acidosis. And this was all in the setting of actually heavy alcohol use. So eventually, it was very clear that he had relapsed, which was what led to the pancytopenia. It's what led to the 2-to-1 AST to ALT. It's what led to probably some degree of relative volume contraction. And then whenever you're starting anybody on an ARB or an ACE inhibitor, and now an SGLT2 inhibitor or metformin, I would just say, talk to your patients and say, listen, man, don't be a hero. If you don't feel good, it's okay if you don't take it that day. All right, because he was like, Doc, I was taking my valsartan. So this probably was some vasoplegia from some volume contraction, but central, as I like, by the way, Dr. Kemper phrased it, the center of gravity here was all the relapse and the alcohol use. So this was thiamine deficiency causing a lactic acidosis in the setting of alcohol use.
Wow, incredible case. It's interesting. Like, we're waiting for the big reveal. So there's POCUS we've had myxomas. We had Dr. Galen did a clot, DVT in transit causing PE in a patient with shock. We've had hydronephrosis, but today you stopped us with a normal echo, and that can be very powerful because you've immediately eliminated, like we were mentioning, the center of gravity. We were like all in on, there's got to be a cardiac cause, right? So we love to do POCUS of the heart, but in this case, this is a normal heart. So now you're like, hey, now we're comfortable in shifting our focus away from that to other causes. And like you mentioned, you highlighted, very important. We get all very excited about lactic acidosis and the increasing lactic acidosis. We worry about things like mesenteric ischemia or infarction or tissue death somewhere. But in this case, yeah, type B, it could be many causes, malignancies, Warburg effect. It could be things that are non-septic, and definitely thiamine deficiency is one of the causes. And as we had related earlier with the alcohol use, and I really appreciate you mentioning about, we don't educate patients on stopping their diuretics. I've had patients come in and they feel sick, and what do? They keep taking the diuretics and then come in massively volume depleted and in AKI. So very important to educate them. If you're not feeling well or you're under the weather, maybe hold your antihypertensive, hold your diuretics, because that could exacerbate the condition. But phenomenal case. It just shows how powerful it is and how it can shift your attention from the organ in focus that you're going in all in on for possibly the cause of, or the center of gravity of the case. And then that way you can look at other things that could be contributing to the patient's disorder. Anne-Marie, any reflections?
I think I like this case because I think it really illustrates also that sometimes time is an excellent diagnostician. Like, you have to gather information and get kind of subsequently more information and try to use like physiology and response to guide it. And sometimes you also have to give it the test of time. And let time determine what's signal and what's noise, because a lot of times there's so many abnormalities that sometimes we have to say, like, what are we going to try to fix now, and then determine later what's signal and like what is noise in the long term.
I think also is very powerful in that don't perform premature closure. A lot of times, like a patient may smell, walk, talk like maybe cardiac disorder, volume depletion. Give some volume and see what happens. Don't just walk away and attribute it to X, Y, or Z, but probe further if there's no resolution of the presenting issues. Can we go on with teaching point? Sammy, mic is all yours.
Yeah, sure. Thank you so much, Dr. Restrepo, for this amazing case and amazing discussion and a lot of pearls by Anne-Marie and Ravi. So thank you all so much. I was just wondering, maybe Dr. Restrepo, if you can comment on that. I was thinking about thiamine deficiency, but like I was always expecting to see like a wide pulse pressure with that. And here it obviously wasn't there. Do you have any explanation for that? Or I know that diseases don't read textbooks, but.
Yeah, so I think that there was probably some concomitant volume contraction, which is probably what narrowed his pulse pressure. I think that if you were to have euvolemic, pure kind of wet berry causing a cardiomyopathy and, you know, all the other horrible things and autonomic neuropathy and everything else that it does, then you could maybe expect the wide pulse pressure. But, you know, I also don't think that things are as scripted as to have to obey. I certainly wouldn't think of a wide pulse pressure as a sine qua non for thiamine deficiency, meaning that you can certainly see thiamine deficiency of varying amounts with a normal or a narrow pulse pressure.
Thank you so much. That makes total sense. All right, I will just go through some quick teaching points. So we had the chief complaint of dizziness or lightheadedness, and we are actually very bad at differentiating that. It's like same as throwing a coin. So we should always ask like more clarifying questions. Are associated symptoms of cardio and pulmonary disease, for example? What is the time course? Are there certain triggers? Is the patient taking any medications? What is the past medical history? Then we had this nice overlap of alcohol use disorder and dizziness, and Ravi and Anne-Marie made us think about volume depletion, cardiotoxicity with low output state, neurotoxicity, for example, cerebellar degeneration, and also nutritional deficiencies, for example, thiamine deficiencies, anemia, Wernicke's. Then we had the finding of orthostasis, which is defined as a decrease in systolic blood pressure above 20 millimeters of mercury or diastolic over 10 millimeters of mercury when standing up. And Anne-Marie taught us her approach to shock, which was awesome. We should think about distributive, obstructive, cardiogenic, and hypovolemic. We should always check a JVP. It would be elevated in obstructive at cardiogenic, and the perfusion. Are the extremities cool or are they warm? And hypotension after fluids makes hypovolemia less likely, but it can also be a sign of marked volume loss. Then we talked about narrow pulse pressure, which would be more compatible with hypovolemia or cardiogenic shock, but also think about adrenal insufficiency when you have a patient with refractory shock. Then we had this interesting finding of refractory lactic acidosis, which can be seen in severe shock, but if it doesn't get better, we should always think about a different mechanism, most notoriously type B lactic acidosis, for example, seen in drugs as metformin, thiamine deficiency, liver cirrhosis, or excessive sympathetic tone. Pancytopenia can be caused by decreased production or peripheral sequestration. When we have a concern for heart failure with seemingly normal cardiac function, we should think about high output heart failure, which can be caused by thiamine deficiency, sepsis, anemia, thyrotoxicosis, AVM, pregnancy, but also myeloproliferative neoplasms can cause it. And lastly, we had a master class on echocardiography. When you do an echocardiogram, you should always check a peristernal long axis, a peristernal short axis, apical 4-chamber view. There's also an apical 3-chamber view. And also never forget to check the IVC. Is it congested? Does it collapse with inspiration? And thank you all so much. Sorry if my internet connection wasn't the best.
Oh, we just lost you at the end there, Sammy, but What a great case to have Sammy back and Anne-Marie back again on VMR. Really appreciate you coming on, and also Daniel Restrepo for coming on and spending his afternoon presenting such a wonderful case, a great friend of CPS and subspecialty VMR. Any closing words, Anne-Marie?
No, just always love learning with everyone. So thanks so much for presenting.
Okay, great. Take care, everybody. Have a great afternoon.
Thanks, everyone.
Bye. Thank you.
Bye.
Bye.